you're like, but we're supposed to be able to diagnose someone in a 30-minute OSCE after talking to them and listening to their heart and lungs. There are some conditions in here that are very difficult to get to. When we do our test, I'm not going to give you those 11-year diagnosis questions. They're going to be very common PCM presenting. And if I start with a polyneuropathy or a mononeuropathy and we work it down to something more specific, great. As long as we can recognize it as it being one of those categories and get close, that's what we want to do, and then we can work with the neurologist. Other things that we want to do is appropriately triage emergency cases, and we'll focus on those one. MS is a huge presenting case, stroke, intracerebral hemorrhage. We'll spend a lot of time on that during phase 2, or excuse me, the second block of this, and then recommend initial course of therapy in accordance with applicable assigned texts. All right, so the way we're approaching neurology is what's called symptom-oriented approach. When you actually look at sorry to jump ahead a little bit, when you actually look at the course schedule of the things we're going through, it's kind of broken into like general groupings of like weakness, and you're like, that's not a neurologic system. But that's what people present with, and that's the way we want to present these things to you, not by like system by system. Pharmacology is nasty with that, where they're like, hey, alpha and beta blockers, and like, I don't know what those things do yet. Alphabetically, they just come first. With this, we're going to try to organize it by symptom that you're going to see in a PCM lab. 32 hours in total. We have 7 class periods for each block. We have 1 extra block built into the first one, so if we kind of spill over, I'm new to teaching. If I go over on time, I apologize ahead of time, but we have a little bit of buffer room. And then we're going to do a review prior to each lecture and the lectures that are the exam themselves. Talking about the exam, you guys don't know my testing. It's a 2-blocker. That's always kind of risky because you're like, what kind of questions is he going to ask? I'll give you some tips as far as what it is. I'm not going to hand you a 50-question review. My first tip for you guys, a lot of slides have some bolded text in them. That's not exclusive or inclusive of the test. That's meant for you as we're reviewing very quickly to say, how do I recognize this? This is a wall of text. Originally, when I received the slide deck, it was just black text on white background, no pictures. I'm like, no one can get anything out of this. It's like reading a textbook. So I highlighted specific things that say, hey, this differentiates it compared to everything else. My other hint for you for this exam is going to be, a lot of these things sound very similar. Everything is going to be like, that's a neuropathy. Everything kind of falls in that category. Nerves are inflamed, and we either have a sensory motor deficit or a combination of the two. That describes everything in this course. Don't worry about those things. Focus on the things that make it different. That could be family history, that could be a weird exam finding, that could be something very specific. And I got one more hint for you for the exam. I said I was going to only do one. I'm feeling generous. All right. When we're talking about special tests, I'm not going to put the name of the special test down. I'm going to put what the motion is. Because a lot of us can say, oh yeah, Frohman sign, classic. And you're like, okay, describe to me what you're actually physically doing with the body. So I'm not going to put the names of special tests because you're not going to receive that on the pants either. That's too easy to do the name brand recognition without actually understanding how to perform or interpret the test. So with special tests, don't be looking for, oh yeah, as long as I can recognize Phelan's sign, I'm going to be good. No, you actually have to be able to say, hey, how do I actually perform this test? That's it for test G2. All right, primary sources of information. Originally it was some texts. If you look in the syllabi, it's a really old version of Current. I'm trying to update those things as we go. That being said, if you find things that are up to date on up to date, or you go onto open evidence and you find something that says, hey, this is new and exciting, or I'm combating this test question because I found newer things, I'll entertain it all day. I'm not going to hold you guys accountable to a very old text. So everything is open gamut. If you find one really random case in the very bottom of the list online, we'll talk about that a little bit, but open evidence and up-to-date are both valid sources if we want to have further discussion on things. The other thing I want to include you guys into, how many people have pants prep girls already? Got one. All right. What I did was I took that book, I said, AI, tell me the things I need to throw in the slides, and I shook it all in there. So a ton of details from pants prep girls are going to end up in the slides. The reason why that's important is I don't want you to get to the end of this block and say, okay, I'm going to dump neurology for a little bit, get to the pants, open up pants prep pearls and say, I don't recognize this version of neurology. It's cluing me into different findings that I wasn't expecting. So I'm going to tie these things into pants prep pearls a little bit so that way when you actually start studying for the pants and get that book, if you want to get it now, start highlighting as we go through the course, fantastic. Save it for Christmas if you want to. It's not urgent. But as you move, especially my sophomores, juniors, a lot of you guys probably have pants prep pearls already. Start working as you go through those clinical rotations to help use it as a study guide, because it's going to help when you're actually studying for the pants. You say, hey, I recognize this originally, not trying to reteach it to yourself twice. All right. Blueprint for the pants, the things that we're actually trying to cover. As you look, it's actually pretty small. There's not like a ton of things. You're like, I feel like we could cover most of these things in an afternoon with each other. When you actually dig into some of the details of these ones, specifically, let me get my laser pointer. When you actually deal with encephalopathic disorders, that tends to cover a lot of ground there. Cranial nerve palsies, there's a ton of those. There's a lot of smaller things kind of baked into these things. Neoplasms can cover a ton of territory there. Nerve disorders, it's not all inclusive of those. There's more that can potentially be under these. Just know that, hey, even though the list is pretty short, there's a lot of little nitnoid details. If you find yourself going down a random rabbit hole, and you're like, I think I'm kind of far out, where does it fit within this PANTS blueprint? Go back to this slide, it'll help you, and pay attention to the blueprints. MS is one of the biggest ones that you're gonna see. They keep retesting it a billion times. Last G2 for my exam, I'm gonna test a bunch of questions on MS. It's just something we like to focus on clinically because we see it a ton. We see it on exams a ton for the PANTS, so I'm gonna put it on our test so it's not wildly desynced and I'm asking you guys crazy questions of things that take 11 years to diagnose. All right. I'm assuming you guys are familiar with the PAEA end of rotation that's coming up for phase 2. If you notice, there's no PAEA exam for neurology. It's actually baked into all the individual rotations, the main ones: family med, internal med, emergency med, surgery. Pay attention as you're taking these exams and say, hey, I have to dust off neurology. There's not going to be a single neurology exam. I don't have to look at that again until I hit that. Pay attention to those individual tests because it kind of surprised me. I was like, oh, there's no PAEA end of rotation exam for neurology. It's baked into all the individual ones. But we'll see one for family med, internal med. EMed has a ton, surgery. The thing to pay attention to is approach neurology from that perspective. The EMed end of rotation exam is going to ask EMed-like questions. Person presenting with stroke, what am I doing? The family med rotation, that's going to be more of those follow-ups, kind of long-term things. And then internal medicine, think of people that are, severe disability, they're in an internal medicine setting. Just take it from that approach for each of those exams as you go. And then surgery is a little bit of a weird one because we start getting into neurosurgery diagnoses, neurosurgery procedures. We don't do a ton of neurosurgery in this course. I'll get to the bottom of exactly what's going on with that. The surgery PAEA bundle was kind of revised recently. I'll make sure we capture those things by the end of the exam. I'll let you guys know exactly what we're looking for those ones. But again, carpal tunnel syndrome, epidermal hematoma, I got neurologic neoplasms, all those are bread and butter things for neurology. And then lastly, pediatrics has like one or two weird ones in there. We kind of combine neurology and psych in a few of these ones. All right. Testing aside, what are we going to see as PCMs that are neurology? Very rarely does a patient come in with, I have a neurology complaint. They're going to come in with, hey, I have headaches and they're really weird. My vision gets all crazy around the side of it. Migraine headaches, tension type headaches, bread and butter for a PCM. I see it on a weekly basis. Syncope, pre-syncope, especially active duty, that's a big deal because a lot of these guys are exercising, they have pre-syncopal episodes. Being very comfortable working through a patient on syncope and pre-syncope, so we're not just brushing it off and saying, oh, you have a case of the vapors. No, this is a real thing, that's a southern diagnosis. I'm sorry if anyone has those. Don't diagnose them with that. Does anyone know what radiculopathy is? I think we just finished up with ortho in one of the rooms. They're pinching over there right now. Yes. So when we see a nerve pinch, we can get sort of pain that kind of comes with that. Radiculopathy, it is a neuro condition because as a result of that, we can have weakness and nerves are being affected. All right, concussions and post-concussion syndromes. Once I finished here at IPAC, I was class 17-2. My first place I went to was an airborne unit, and so we were dealing with concussions on a daily basis. It was constant every time an airborne happened. It's like, hey, how serious are all these head bumps? Getting very confident dealing with concussion symptoms, initial management of that, and follow-up care, because you're going to see these guys 14 days out. You're going to see these guys a year later. They continue to come in with these things. Tremor is one of those weird ones that I see a ton of, and it's especially people that are just getting out. For whatever reason, they're really stressed out, and for every single time I hand them their exit physical, they start developing this weird intention tremor. It happened to me multiple times. But you'll see a lot of physiologic tremor that you need to work up and say, hey, how serious is this? Seizure, a ton of it. Can you be on active duty and have seizures? No? Yes? Yes, you can. You can be treated with anti-seizure meds, and you actually have a 12-month to a year-long period where you're expected to remain seizure-free. So you can be retained on active duty, and you will deal with soldiers that are in that 6-month period. It's not like, oh, he had a seizure, you're out of the military, you're going to be keeping them for up to a year while you're working them through that. Do people initially tell you they had a seizure? No, because they think they're going to get kicked out of the military. So we have to get very good at recognizing that prodromal symptoms. They're very specific a lot of times. It's, hey, 30 minutes worth of confusion afterwards. That's not a syncopal episode. Did your friends see you doing the kick and chicken on the ground? I'm sure there's a medical and doctor word for it. We'll get to it eventually. I'll give you a better word for tonic-clonic reaction. There it is. Okay. Dizziness and vertigo is another weird one. They kind of come in with dizziness, and you guys have to tease out. Dizziness is a weird word because you can diagnose someone with dizziness, but they don't like that. You have to fit it, hey, is this vertigo? Is this presyncopal? We'll work through the algorithm how to get to the bottom of that. Does anyone know what an incidentalloma is yet? Have we had radiology? Some people have. I see some nodding of heads there. For the people that don't know yet, a lot of times I'll get brain MRIs because they come in with one of those complaints, and then they find a pituitary adenoma or a microadenoma. That's the pituitary gland under a centimeter, and you're like, what do I do with this? You'd be shocked at the number of times I've actually dealt with it. It's like 5 or 6 times, probably within like a 2-year period. It's a decent amount. You got to get very comfortable dealing with it. It's not a lot, but it's weird that it happens that many times. Last 2 things. So we've had HENT and I think ophthalmology for the juniors, not so much the sophomores. We share a lot of, you guys have had it too? Oh, hell yeah. So there's a lot of very common ground between vision that kind of strays into neurology. And then the same thing with HENT, because of those cranial nerves and where they're located. Initially, they come in with like blurry vision, and they're like, hey, I have this weird diplopia, and my eyeball is over here looking like Stephen Buscemi. And you say, oh, I need to go through my cranial nerve palsies that Major McMahon taught me 7 years ago. All right, course schedule for us. Today, we're just gonna go through a focused history and physical and kind of a brief introduction. It was a little longer than I thought I was gonna be. 102 slides today. A lot of it just is kind of spread out. It's not a ton of content that is testable. That being said, there's about 5 questions throughout all of this. If you see a long chart, don't try to memorize it. I'm going to try to give you an approach because my people in ClinCore right now, we see patients that have belly pain. We feel very comfortable doing OPQ or ST. Guy has ankle pain all day. Has an eyeball complaint. All right, OPQ or ST gets a little more complex. Guy shows up with just hypertension. How do I fit OPQ or ST into that? Guy shows up with a neurology complaint. Those get very weird. So we're going to kind of go through how to ask OPQ or ST, how to approach a physical, and just, hey, how do I actually approach a patient once I recognize, hey, this is a neurologic. And there, I already kind of talked about, but we're doing a very symptom-based approach. If you're kind of confused because you're like, hey, you talked about central lesions one day, but now we're talking about movement disorders, just go back to, hey, it's named a weird thing because we're trying to do symptoms-based approach. That way you can approach a patient and say, hey, I think I'm dealing with weakness. Let me put that in my mind that kind of comes together this way. All right, so today, going over HMP, good times. All right, first step, the thing that we got to be thinking in our head before we start taking a history is, all right, I'm trying to find the anatomy and I'm trying to localize the lesion. You'll hear that come up a lot because we see something weird going on with the nerves and it can spread all the way down. It can be anywhere from the brain down to where the lesion happens. And there might be specific signs that says, hey, I think the lesion is here. Why don't we just order an MRI and tell us where the lesion is every single time? It's expensive. I don't care about expense. The government pays for everything. Right? So it takes forever. We may be waiting 30 days. Does an MRI always show us what we want to see? No. You could come up with a perfectly stone-cold normal MRI with abnormal findings. Or even worse, what about those incidentalomas? My guys know that every time I take an MRI of the wrist, I'm going to have at least 4 different findings on it. I don't know why. Wrists are just nasty like that. Sometimes you order the MRI and you end up with way more findings than you were hoping for, and you're like, how many of these are clinically significant? How many of these aren't? So we have to clinically correlate the findings. For whatever reason, radiologists always like saying that because you're like, I don't know what's wrong. Correlate it clinically. And you're like, okay, go back to step 1, doing the HMP. So when we're taking a neurologic history, I'll tell you a story about my first time on neurology rotation. The neurologist said, here's a 31-point neuro exam. You're going to do it the same way every single, I don't remember any of it. He said, here's a 31-point neuro exam. Do it the same way every single time. Go see this patient. I was like, all right, sure. And I go see the patient, and he tells me to, hey, get out of here. I have to, I'm a PA student, I'm here to exam. He's like, no, take your clipboard and go. I'm like, okay. So I go back to the attendant, and he's like, oh, I'll show you. And he grabs me by the pocket and walks me down with his clipboard too. We have 2 clipboards now. And the guy takes a look at him and he says, I want you to take your clipboard and shove it up your butt. There's a nastier word that he said, but I don't want to get bad reviews. But Karyaga's heard this story before. But I was just like, all right, he just outright refused physical exam. So this 31 point, like very like complex, like it was like, what's the boxer's name? Mike Tyson. Everyone has a plan until they get punched in the mouth. And I got punched in the mouth, and I was like, I don't know how to examine this guy. I think he had a stroke, but he's refusing everything. He told me to do something with a clipboard that I won't say in kind company again. When you're trying to approach a neurologic patient, just know that they might be demented, they might have delirium, and we'll go over separating the two of those. What do we do when we have a patient that just refuses everything? And that will happen. Document. Okay, who else is available to us? What do we have? It's like with the patient though. Family members, right? When was the last time this person was normal? Is he always like that? This is bizarre. Asking those questions and digging it out, especially if they are of an altered mental status. Hey, who was around this person that knows what was going on, or was it consistent? EMS, if you're in the emergency medicine realm, they may be there to kind of give you some more story, especially if they're doing wall time. Moving into the OPQRST. So, onset, you guys know that pretty well. If I see something that has a very sudden onset with slow improvement, I start thinking more vascular events, I start thinking seizure, I start thinking migraines. I'll put in a couple of disease states throughout this. Don't worry if you don't know what those are 100% yet, because we're tying these into later lessons to say, oh, this has kind of a slow onset. But sudden things, those tend to be vascular in nature more often than not. If something has a very gradual kind of worsening over months to years, is that typically vascular in nature? Not so much. That's not how strokes present. More often, those tend to be toxic, metabolic, infectious, those inflammatory things. MS kind of comes across as that a lot of times, or tumors, because those tend to be slow growing. And then, does anyone know what the term relapsing remitting means? Mm-hmm. Kind of back and forth. I saw it with the finger. That was a good descriptor. All right, so relapsing means something gets better, and then remitting means it gets worse, or vice versa. Forget which. Relapsing means, hey, I'm relapsing into it, and then remitting means I'm getting better. That's very specific for MS, because things will get better, worse, better, worse, better, worse. And then history of trauma, especially with the onset of things. Did you get bumped in the head? Because people don't offer that a lot of times. All right, provocative and palliative factors. What have you done to make your brain feel better? All right, stress tends to be a provocative factor for a lot of people. Asking those questions is important. How frequently are we taking pain medications? That becomes very important for medication overuse headaches. I didn't realize how easy it is to put someone in medication overuse headache territory just with Tylenol and ibuprofen. It's like, oh, they have to be on it for months. No, that like 14-day supply you give people Tylenol and ibuprofen, you're begging for a medication overuse headache a lot of times. We still do it, but it's something to pay attention to. It's easier to put someone in those states. Does light or noise make your headache better or worse? We start thinking of photophobia, fear of the light. It's not that we're scared of it, it's just very painful to our eyes. And then phonophobia, we're scared of noise. Again, loud noises. How many people have medics prior gone in with a headache patient and the lights off in the room? Happened a couple of times. Yeah, we've all seen it, and you're like, are you always like this? Be nice to them, just hang out with them in the dark and see them, because it's very painful to have that light on. And then headache that comes with reading. We start thinking ocular things. A lot of times with our headache syndromes, we have a lot of eye-related issues. They may need glasses, but always tie that into, hey, this guy has a headache, check the eyes, do a quick visual acuity for me. So we might develop, does anyone know what the term diplopia is? I think that's a dubstep artist. Or is that diplo?
Double vision.
Double vision. We can have different brands of it. We can have it where it kind of goes off to the side, or we can have it go vertically. Those are concerning for optical nerve palsies, and we'll spend some time on that as we go through the optical nerve. Quality. Pretty straightforward. What does nerve pain feel like? Burning sensation. It could be sharp, kind of tingly. Is nerve pain kind of achy? Not really. That's more suggestive of musculoskeletal complaint. But as you're dealing with those peripheral neuropathies, start asking like, hey, does it feel like nerve pain? Because the patient may tell you, yeah, it's this weird tingling sensation every time I bump it. You can ask them outright, but then ask those leading questions of, hey, is it kind of burning? Is it kind of tingling? Is it more achy, crampy? All right, moving into the region of symptoms and radiation. Think laterality with a lot of these things, because a lot of these things start in one side of the brain and end up on the other side of the body, or vice versa. And then when we start dealing with peripheral neuropathies, hey, we bump a nerve here, but it spreads along this distribution. That tells me one thing. Or it stays on this dermatoma only. That kind of tells me more towards the spine. Figuring out where things go. Radiation was kind of built for this portion of it. That tells you exactly, hey, localize the lesion a lot better when I understand the anatomy of, hey, here's a peripheral nerve distribution. Hey, here's a dermatomal distribution. Paying attention to those things. Has anyone heard of a stocking or glove distribution before? I think that comes up in medical literature a lot. We think diabetes with that. So what that is, and there's other things that can cause that, is a peripheral neuropathy called a polyneuropathy, meaning the nerves are affected systemically. It's not, hey, it only hurts on one side. It's both sides equally. Is it that I got ulnar nerve issues on both sides, or do I have something going on systemically that's causing it? Polyneuropathy should clue you into that. So a stocking with the feet, got it wrong, and gloves with the hands. Why is it important that it's starting distally? So some of these things are actually length dependent, meaning the further it is, the more nerves are exposed to something systemically, the more likely it is to be affected. So we'll see that in a lot of disease states where it starts far away and it works its way up because there's more nerve that can be affected on the way there. And then the pattern of sensory loss, dermatomal versus nerve radiculopathy, that'll make a lot of money for you saying, hey, the issue's here, or no, it's in the spine. And then severity of symptoms, the pain analog scale, how bad is it? When we deal with things that aren't painful, start thinking about how much does it affect the patient. So we talk about ADLs. Does anyone know what the term ADL means?
Activities of daily life.
Activities of daily life. How much does this affect your ability to dress, change yourself, drive, make food, all the typical things? Ask those questions, especially when you deal with something that might be disabling or affects upper extremities. Think about how much does this affect you personally. If the pain scale is great for pain, you can't rate other things that aren't painful using a 0 to 10 scale. That's not really recognized. I think we kind of work our way into it, but ask the questions that matter. Be like, hey, on a day-to-day basis, does this affect you? Yes or no? All right, the timing of things is very important. Does everyone know the meaning of acute versus subacute versus chronic? I think days, weeks, months, that generally keeps you pretty straight for most of these things. And then when we deal with things that are episodic, I spend a lot more time here. I say, hey, how many times are we having episodes per month, per week, per year? Depending upon how frequently it's happening, because that helps identify that severity. And then how long do these episodes last for? You can use these for chest palpitations, you can use this for weird neuropathies. And then when do we first start having episodes? And then ask for the triggers that happen with each of these episodes. Certain foods, stress, sleep deprivation are very common. Does anyone know the term catamenial? That's a good one. It's actually related to the menses. So a lot of times we can have migraines related to our menstrual cycle. It's a very important. A guy can't have a catamenial, but women definitely pay attention to that one. That's a board question word that pops up a lot of times. All right, medications, pain relievers are very common. We see overuse with Tylenol, ibuprofen, and psychiatric medications. Those are important for us to pay attention to because they have a lot of neurotropic effects as well as psychotropic, meaning it affects our neurology as well as our psyche. Herbals tend to have a lot of neurotropic effects. Who's done pre-workout and makes your face tingle? Hell yeah. It's okay, we're just giving ourselves a neuropathy every single time. And then street drugs, I feel like we don't see as many street drugs, but then we see more. Jargon matters, just ask them what it means. Don't try to learn your local, like, oh, that's a soup drug in Baltimore, I know that one. Vape pens tend to be a very common offender. It's just like, oh, he vapes. It's like, well, what's actually in the vape pen? And a lot of times with my soldiers, I've seen it be like a combination of ecstasy, THC, and then I forget what else they put in it. Some MDMA pops up sometimes. Where's that ecstasy? I see a lot of vape pens be these weird combo drugs. I see a lot of patients have like very sudden episodic weird neurologic conditions because of vape pens. Kratom's another big one. Has anyone heard of the term, this? You won't find this in a textbook. It's not a Power of the Jedi will teach you. Gas station sober. ER loves this word. It's basically, hey, is he on drugs? Hey, he's gas station sober. It's basically, hey, he's as sober as the things you can find in your local gas station, which tends to be a lot of different substances that we don't know what they are. Kratom is one. Just know it's like, hey, you got your hardcore street drugs, you got your black tar heroin, and I got this whole weird subset of vape pens, weird pills, online stuff. Just pay attention to those ones. Make sure don't use the term gas station sober with a preceptor until like they use the term first. ER is the first one to use that. All right, past medical and surgical history. When we ask an older patient that had a stroke their medical history, what are they going to give us? The entire Napoleonic history. When I was a small boy of 7, when rickets was still a thing. No, glue them right into neurology, stay focused on that. Don't be afraid to switch over to closed-ended questions, because very rarely are they going to offer you a very comprehensive neurological focused history. Think, hey, do you have any history of headaches, seizures, head trauma, drug, alcohol abuse, CNS infections, psych disorders? We'll go into why psych disorders are important to us. And then implantable devices, I think, was another cool thing. Does anyone know what that weird one, this deep brain stimulation, has anyone seen or heard of that before? Yeah? Seizures is one. What's another like movement disorder that we've seen? Have we heard of Parkinson's disorder? We can see a lot of very positive effects from this. People will have this and be like, I don't have anything. It's like, you have a thing implanted in your brain. Yeah, I've never had brain surgery, because they don't equate it to these things. The other one, I see one down here, it's doing the hypoglossal nerve and it's attached onto the lungs. Does anyone have pulmonology yet? No, so it's actually called the Inspire device. We'll see this very commonly. It's used for obstructive sleep apnea. And it actually creates just enough tone to help separate that airway to help with obstructive sleep apnea. It's getting people off CPAP machines, but these are becoming more and more common. So pay attention, ask them about surgical. Hey, most people won't say, yeah, I've had brain surgery, but then you ask, do you have implantable devices? That becomes important when we start ordering what study? MRI. Does it always go in the same way it went in? I'm sorry, go ahead. Yeah, absolutely. You can pay attention to cochlear implants, because where's that implant going into? The cochlear. Yeah, it's interacting with nerves and stimulating those things. It's important to know that history, especially if you're like, hey, have you always had sensory neural hearing loss? Yeah, I have a cochlear implant. Have you turned it on? No. Worthwhile to ask the history, because a lot of people don't think, if you're asking the question, hey, is that neurologic adjacent? The patient's asking the same thing too. So no, HEN didn't give it to me. I've never seen a neurologist. Regarding our social history, alcohol use, tobacco use, we see a lot of neuropathies with alcohol use. Tobacco, is that a big risk factor? Especially for vascular things, we see that later on in life, it's going to be a big risk factor for stroke. When we start dealing with education, why is that important for us? We start thinking, hey, what's our cognitive baseline? Because you may see someone that says, hey, this person has like several PhDs as a doctor and is not performing like a doctor should be. More educated people are going to show cognitive decline more dramatically. If you have less education or are less experienced in these things, it might be more difficult to show some of these things. Employment. Why is employment important? We think occupational exposures, industrial exposure. MS has a huge connection with this. A lot of things as you get exposed, oh, I work in a cell phone factory. It's like, okay, this guy's been exposed to a lot of weird things. Oddly enough, cell phone factory workers have a super high rate of MS. Travel is important as always, and is there support at home? It's kind of a weird question we've never really asked with social history. Has anyone heard of a social admission before? Jules has. I think when we're in the hospital, you as well, when we're in the hospital and we have a patient that might be medically stable, but if I send them home, they're not going to do well because of X, Y, and Z. It's called a social event. Be careful of who you admit that to, because sometimes they're like, we don't do social events. That can be a very common thing. It's like, hey, this patient's at greater risk for themselves. They're medically stable, but we need more help at home and we need more management kind of further out. But ask the support at home question, especially if we're thinking ADLs. All right, family history is important. I'm going to rattle off a couple of diseases. We might not know these ones yet, but just kind of bookmark it in your brain that, hey, I'm asking family history on these ones, because that's something that differentiates it compared to a lot of other things and may have test questions related to it. So Charcot-Marie tooth disease, Huntington's disease, MS, ALS, also known as Lou Gehrig's disease, and then Parkinson's and Alzheimer's also have a relation to each other. Some of these things might be autosomal dominant, and some of these things might be autosomal recessive. Which one am I more worried about? Dominant, because if one of the parents has it, you're pretty much guaranteed to have what that is. Because if you get it from either, I guess it's a 50-50 chance at that point if you don't get it. But there's a much higher rate. Recessive, is that as risky? No, because then both parents need to have this weird kind of gene, but it's still important to pay attention to that family history. We pay attention to psychiatric disorders. I think we just finished up with psych. I saw James in one of the classrooms. Are we familiar with what conversion disorder is yet? Yes, yeah, I think we got some bases, yes. So I have someone that has conversion disorder. A lot of times the symptoms they display end up being weird neurologic things because they're weird, and our brain is like, okay, I need to show something systemically that I have trauma done to me. And it may come across as a weird movement disorder, it may come across as a weird tremor, it may come across as like a really mixed, there's actually one of the gates that's known as aphasia. It may come across as, hey, this doesn't really match anything. You're showing me cranial nerve palsies, some things cross the midline, I've got some weird stuff down here. This doesn't fit a typical picture. Are these patients with conversion disorder taking? No, they genuinely, like, they've convinced they've had it. I actually have one patient that we've dealt with that had conversion disorder. He had pseudo-seizures. And it got to the point where he was intubated by, I think it was EMS or somewhere throughout the pathway with like minimal sedation. And I'm like, wow, he committed to the bit to like be intubated. And he was not well after that happened. But in his brain, it was frustrating for him because like, everyone's telling me I'm faking these seizures, like it's really happening to me. It was very difficult to deal with. So take their conversion disorder guys seriously. They may have a whole bunch of other things surrounding them. We're like, oh, that guy's a S-bag soldier. I'm not allowed to say naughty words. Put your blinders onto that. Treat it like they're a normal human being. Treat it as if they were civilian and they're presenting with weird things. Review of systems. It's that the 2807. That's the original OG review of systems. Don't have your patients fill one out every single time, but that's basically what we're asking. Always ask your general view of systems for my guys that I do claim core with. We kind of try to develop that fund of knowledge as I ask these questions every single time. Always important to ask those ones. I want to increase your fund of knowledge and give you some like neuro-specific ones. There's nothing worse when you're like asking review of systems for eyeballs and you're like, do you have a family history of having eyeballs? I don't know, weird. It's hard when you get into the weird subcategories. So kind of overall in general for our nervous system, ask if they have headache, loss of consciousness, memory loss, insomnia, attention, concentration issues, or disorientation gets lost easily. Don't memorize any of these. I'm not going to ask you, hey, give me this is for your own development as asking questions, not test questions here. With the cranial nerves, start asking about the visual changes and deficits, especially if something in the face is affected. I'm asking questions about diplopia. Do we have double vision, facial numbness, deafness, and dysphagia? That's the most common presenting signs I see a lot of times with cranial nerve disorders. When I'm dealing with limb, motory, sensory, and I'm dealing with those radiculopathies, I have back pain, it shoots down my leg. Congratulations, you have a neuro complaint. I'm looking for paresthesias, radiculopathies, paralysis. What's a paresthesia versus a radiculopathy? What's the difference there? Pins and needles, it might be an odd sensation, versus radiculopathy kind of more lends itself to be a painful sensation. You can use them interchangeably. People aren't going to beat you up over that. But if you kind of get test questions from like, what's the difference between this or define that? Just kind of know like, hey, I see these two terms. I use them interchangeably. I actually looked up the difference, and hey, it's actually a radiculopathy. What's paralysis? Things don't move, right? We talk about palsies too, where like it's not really working right. We kind of use those interchangeably. Is a palsy always like 100%, or might it be like a little bit of difficulty with it? Versus paralysis lends itself to, hey, that doesn't move at all. And then tremors, weakness. What's dyskinesia?
Abnormal movement.
I think kind of like clumsiness. It might be like, we kind of, I take dyskinesia, apraxia to kind of mean very similar things where I have difficulty with motion. Dyskinesia specifically, think cerebellum is affected, where my body has a lot of excessive movements with it when I'm trying to do something intentionally. All right, moving on into cerebellar, that's that small portion of the brain back there. We'll spend some time going over the neuroanatomy of each other. Very dense collection of nerves coordinates all our movements for us. That can cause altered coordination. That can cause that disequilibrium, that dizziness and vertigo, and tremor as well, that dyskinesia like we were talking about. And don't be afraid to ask psych history. I like psych and cover psych, but ask through those things because conversion disorder is real, and psych and neuro have kind of a weird junction with each other, as does ortho for all the spine-related things, ENT, and then ophtho kind of have like the biggest connections in with neurology. All right, red flags, we always like to identify these ones, and anyone that's worked in a medic role has asked these questions probably a billion times. Worst headache of your life should be an instant, all right, we gotta probably do a lumbar puncture. And then thunderclap headaches, sudden onset, always pay attention to those ones. Don't just say, is this the second worst headache of your life? Because at that point, yeah, this is, you know when it's happening. Every headache is the worst one I've ever had, and they just get progressively worse. That should be a red flag too. All right. Sudden blindness, I think that's pretty obvious. If it's one-sided, that's pretty bad. If it's both-sided, that's even worse. But we'll pay attention to some of those reasons that even if it goes away, always chase those ones down and take it seriously. People will say, I can't see, and then you do the visual acuity, it's just really bad. Differentiate out, I can't see versus, hey, I have visual field deficits versus, no, I can't see anything, it's completely gone. You have to tease those out. And then bowel and bladder incontinence, always bad. What are we thinking of when we're dealing with back pain and bowel and bladder incontinence? Spinal cord injury. What's the very specific one where we get that paresthesias in between the thighs? Have we done this in ortho yet? We haven't done ortho spine. Do we know cardiac Klein syndrome? I think the juniors probably do. All right, we always pay attention to that with back pain where, hey, I had one patient where it's like, all right, he's back pain, I'll go see him real quick. And they say, no, he peed his pants. I go, oh crap. And I walked out into the waiting room, it was there, it's big. It's like, I peed my pants. I'm like, okay, come on back, this is an emergency. Because now we're looking out for compression of the spinal canal. And then suicidal ideation of the plan. Always ask it. Don't get roped into like, I'm doing very specific neurology things. Oh, by the way, the patient's suicidal. A lot of these conditions have a psychological component to them. So always pay attention to that. Don't just rope yourself into paying attention to one very specific thing. And then I wanted to throw this in for you guys. It's the SNOOP acronym. Don't memorize this one. It's basically the signs and symptoms when we deal with headaches. Like, hey, when is this one actually overly concerning? So we're thinking that's the slowest I can make it go. I'm thinking of signs and symptoms of systemic stuff going on with my headaches. I'm thinking of neurologic symptoms. Hey, do I have something wrong going on with is there a focal neural deficit going on with it? Sudden onset, postcoital happens a lot of times with these headaches too. That's very concerning. Pay attention. Does everyone know what postcoital is? After sex? Okay. And then before sex. That's even worse. All right. We deal with older patients over the age of 60. Our hackles should be raised immediately because a lot of injuries can happen to the brain as we age and vascular issues
My man's
happen.
a dog.
Progressive, it's getting worse and worse and worse. Don't just give them more and more and more Tylenol. That's going to end well for us. And then we got positional changes, precipitators of something weird happened. We bumped our head and now we have headaches. Or papilledema. Does everyone know what papilledema is? Oh yeah. Oh yeah. Do you have like a billion test question? I'm sorry, I hit a nerve. It's a neuro journey. We'll go 5 more minutes and we'll take a break so we're offset with the other classes. Or do you guys want to take one now? You want to keep going for another 5? All right, we'll finish at 50. All right, so we move into our physical exam. That's a good HMP, it's a good ROS. We looked for our red flags. We're moving into how to do our physical exam. With our general exam, our mental status exam, cranial nerves, motor system reflexes, sensory system coordination gates. This is what we had. I think we just went over this with the sophomores in Clin Skills 2. You guys, the juniors may have gotten this a few semesters ago. We're going to go kind of review it real quick. We're going to add what those abnormal findings are. I feel confident I've got your guys' ability to like follow a checklist and do an exam. That's not difficult. The difference is, hey, now we actually need to start looking for abnormal findings. I say abnormal, so it's like easy to see the difference and don't have a speech impediment. We start looking we'll identify what some of those abnormal findings are, and then we'll start saying, hey, this abnormal finding on this exam we taught you guys, this is the disease state it's associated to. Today's just a review of, hey, here's baseline neuro, because I only taught half of you guys. Here's baseline neuro exam, it's the same. The one you get from IPAP is a good neuro exam. Don't let the neurologist tell you, oh, it's 31 points and you have to do all these weird things. It's okay, just use this one. General exam, everyone gets vital signs. Everyone gets heart and lungs. You need to do it to pass IPAP. The other thing, and this happened to me a lot with concussions, I didn't pay attention to the head. I said, oh, he has a concussion. Let me talk to him. Hey, this looks great on ZNO times this. And he has this big knot on the back of his head. And I'm talking to him the whole time. And he turns his head violently and I see the bulge. And I'm like, oh crap, I need to start examining the actual cranium. Modify your HENT exam to actually look for signs of trauma. Make sure someone doesn't bump their head and actually has secondary trauma to that. Because you can have head trauma without concussion. That's the thing. You can have lacerations. You can have goose eggs. All these things can happen. All right. I think for the sophomores, they're familiar with this. For the juniors, this might be a little new. The only takeaway I want, there's not going to be a crazy test question on what's step 5 of the mental step. There's not one like that. Memorize the acronym aseptic. You don't have to memorize what the things are within that. Just know, hey, Google search this if someone sends me off to do it in their mental status exam people. So, The A, I'm looking at the appearance and behavior of the person. That's talking about their level of consciousness, and I think we've gone over alert and oriented times 1, 2, 3, 4. Can you have 5? That's too many. That's self-actualization. Ignore that one. What's the fourth A and O? If you say 1, 2, 3, person, place, time. Don't ask like just 4 or 3 random questions. Very specifically ask, do you know who you are? Do you know where you are? Do you know what time it is? What's the fourth one? What is it? I heard financial. Event. So situational. You know why or that offers a little bit more insight. Which one are we supposed to use? Just use whichever one your sponsoring institution uses. Either or is perfectly acceptable. All right. We start talking about speech and language. 2 different types of aphanasias. We'll talk about Wernicke's or Wernicke's. The Germans pronounce it Wernicke's. And then we'll also talk about Broca's, which is broken speech. We'll pay a little closer attention to that. Oops, should fuck it up perfectly. All right, moving on to the E, the P, the T, and the I. Emotions. We're asking, hey, how does the patient feel? Because again, we have a close tie in with psychology. You may use this with insight when we do a mental status exam. More commonly, I saw psychologists doing this than neurologists. And then perceptions. We talk about illusions and hallucinations. What's the difference between an illusion and an hallucination? I had to look this one up, don't worry. So a hallucination, I take LSD, I go in a dark closet, there's no external stimuli, I start having hallucinations. It's like your cat, close it in the dark and its eyes are bugging out because it's seeing a bunch of things. And then when I start dealing with illusions, that's a set sensory thing. I'm looking at my man right here, but now he's making nasty faces at me. I'm having an illusion that that's actually, you're not actually, you can if you want to. All right. Don't worry about the name brand recognition difference of that. Just look up, you're like, hey, why am I talking about 2 different things? What's the difference? All right, thought processes, content versus process. Hey, do we process things properly? And what's actually within our thoughts? We have delusions. Delusions is, hey, do I have fake perceptions? I am the Queen of France. And compulsions, what's a compulsion? It's like that anxiety that I have to do this thing or else I'm gonna freak out. We think of obsessive compulsive disorder, obsessive hand washing, leaving doors. Just kind of take that and say, hey, a little bit less. We have things that we feel like we need to do. And then insight. Insight, I like this one. It's really important. It's actually when I get mental status exams as a PCM for a cover specialist, I look at the insight right away. Because that tells me, hey, does this person know what's going on with them, or do they have no clue and it's going to be an uphill battle? And then judgment. Are we making good decisions or are we making bad decisions? And lastly, we have cognitive function. There's a whole bunch of random tests you can do. We'll go over the MOCA exam as well as the mini mental status exam, which are good kind of cognitive function things. They're kind of set things. Who's done a MACE exam? Cosmetics. I think I got a couple of hands. Again, MACE exam is a very good kind of cognitive function thing. They're all kind of very different screening things. I'll show you some of the differences between the 2 of them. But some of the things we can do is the orientation to A&O times 3. We can look at memory. So we care about long-term memory. So that's like, hey, name the last 3 presidents. We care about short-term memory. I'm going to list off 5 words, read them back to me. And then a few minutes later, we say, all right, it's been 5 minutes. Can you read those back to me again? And then serial 7's attention. Hey, can you count up from 0 or count back from 99 with 7's? I think I have difficulty with that baseline. Or spell the world backwards. That one's difficult too. Calculations, simple calculations with the patient, abstract thinking, ask them a weird question that requires them to say something like, what does don't count your chickens before they hatch mean? For someone that does random works, you're like, oh, don't expect things to happen before they happen. But someone else may like, chickens, why are they having eggs that hatch? All right, and then lastly, with our construction ability, this is a very weird one. You can Google, I didn't find a good image, but you can Google search like a person with Alzheimer's syndrome. When they try to draw a clock, for whatever reason, the numbers are all bunched up on one side, or they have a lot of spatial issues. For whatever reason, drawing a clock is like inherently difficult because you're putting numbers and orientation to each other. And that can be incredibly difficult for people. Here's an example of a mental status exam. I'll let you guys read that on your own. I won't belabor the point. That's just kind of a quick example that was on like stat pros and like, here's what an ER expects a mental status exam to look like. If you're doing this in real life, look up aseptic. Find a dot phrase that works really well for you so you can just like tick off the blocks and say, hey, I did a mental status exam. Very rarely do we do the full mental status exam in emergency situations. More often than not, I'm sorry, AMSIT is the other version that we may see. Did Psych talk about AMSIT or what did they use? You can use whichever one you want. They do the same exact thing. It's just an acronym describing the exact same thing. You'll see aseptic more commonly in use. AMSIT is an additional one that you'll see. I like this one, it has a little checkbox on it. Either one's perfectly fine. I'm not going to ask you questions like, hey, what's the fourth step of this when we have two different versions? Just know that whatever organization you may be doing AMSIT, or they may be doing aseptic for the mental status exam. All right, the other things we see is the mini mental state exam, which is more kind of that cognitive function thing. Hey, it's just like putting that into like an exact scoreable rubric. A normal score is 24 and above is normal cognitive disorder. Who's someone, I won't go into that. We also see the MOCA exam is very commonly used too. Who's worked in a clinic and seen the MOCA around? Yeah, you trip over them, they're everywhere. We use MOCA more commonly than the mini mental status exam. The difference, just kind of group these together, aseptic and AMSIT, those are your full mental status exams. They're their broad psychiatric and behavioral health assessment. And then we start dealing with the mini mental status exam, the MOCA, that's your screening tool. It gives me a score out of 30 for both of them. MOCA is more commonly used. I like MOCA better because it will tease out that mild cognitive impairment a little bit sooner. But just say, hey, do a mental status exam on this guy. All right, that means do the full thing. Or hey, just do a MOCA on this guy. That's my screening tool. I start off with my screening tool. If it shows abnormal, I'm probably doing the full mental status exam. All right, you guys want to take a 10-minute break? Cool. Sometimes we admit this from our cranial exam, just because, yeah, in IPAP you have like two things that smell like something. Very rarely does that stay in your exam kit. A lot of times you'll see documented cranial nerves 2 through 12, and they're just trying to say, hey, I documented everything but sense of smell. One of the weird things, because I was looking at like reasons why cranial nerve 1 goes out, it's not a very common one. We can see it with head trauma, especially inside the triangle with the nose. Reason being that crib-formed plate, if you look right there, all those little tiny nerves go right through there. And if that ends up getting sheared off, that's an indicator of, hey, we potentially have a very serious skull fracture. Are we familiar with the fork fracture? Have we gone over that in ortho? Start thinking of that, especially if you have a cranial nerve 1 deficit. Think that, hey, that cribiform plate may have sheared off those nerves as they come through. Other things, we have a frontal lobe that's right here that can have masses to it. That's more concerning for pushing on that nerve, causing it to not work anymore. Other than that, it's a really bulky nerve, and it kind of occupies like a pretty open space. We don't see a lot of lesions with cranial nerve 1. What's a really common one we saw a few years ago? COVID. So what was ended up happening is there's support cells that support the nerves. Those ended up being affected by COVID because they shut down. And for whatever reason, people's sense of smell comes back because those support cells turn themselves back on. The nerves, when they don't get the support from all those support cells, they stop functioning. But they stay in place. They just lie dormant so they don't throw off abnormal signals. All right, cranial nerve 2. We have a bunch of different palsies that can happen with one. The one that I want you guys to pay attention to, the one that's testable, it keeps becoming testable, it always pops up. It's something called Marcus gun pupil. Have we heard of that before? With a swinging flashlight, we got it down cold. The way I remember it, because we always see it in like the prize fights where they show up between the eyes and you're like, why is Doc doing that real quick? They're looking for that positive Marcus gun pupil. The way I remember it, because they'll put the term Marcus gun pupil and they'll list off a bunch of other pupils a lot of times. Think, hey, he brought a knife to a gunfight. Think violence. Think, hey, that person's shining the light between. Because I'm looking for damage between the eyes. But that's going to affect cranial nerve 2. So that pupillary reflex, cranial nerve 2 is picking up what the light is coming in, and that cranial nerve 3 is actually affecting what the pupil's actually doing. If you'll notice, some of these reflexes involve 2 different cranial nerves, one going in, one going out. I don't ask too many questions trying to hammer it home, like especially with, I think Clean Skills 2, there was a question about, we may not have had that test yet. Don't get too wrapped around the axle of, hey, it's between 2 different ones. Cranial nerve, this covers this. Oh, I almost gave away the answer. It's not good on the first day. You took Clinton. No? Whoa! You're my counselee. I trusted you. Dang. That's cold. All right. Cranial nerves 3, cranial nerve 4, cranial nerve 6. They all kind of move the eyeball around. We all remember LR6SO4? It's not useful, I'm sorry. It's great for like a one-off test question, but then you actually look at the eye, it does something weird, and you're like, LR6SO4, LR6SO4, and you're like, I can't tell. I'll go over it with you guys because there's some very obvious ones. So cranial nerve 3, remember down and out. So that pupil is going to be kind of down to the outside a little bit, and that pupil is going to be blown, meaning meaning dilated. And we may see a mild ptosis with that as well. We see some crossover between the nerves because they affect one muscle that affects the eyelid going up versus another one affects another one. So down and out, mild ptosis, cranial nerve 3. I have a picture there where it's kind of down to the outside, lone pupil. When I'm dealing with cranial nerve 6, I skipped 4 because 6 is easier to think about. It's an inability to abduct the eye past midline. So as you're doing that H pattern as I go out, one eye is going to stay forward, the other eye is going to track forward. Kind of looks like this, they kind of go cross-eyed, because what that person's doing is they're moving the thing going this way. This eye is the unaffected eye, it goes to the right, but this eye stopped at midline because that adducens nerve, cranial nerve 6, stopped working. Why is that important to us? Where's cranial nerve 6 at? It's like right at the base stem. So we start thinking uncal herniation at that point. It's one of the first nerves that gets affected with that. All right, so we covered the easy ones. Cranial nerve 3, down and out, 2 easy, mild ptosis. Cranial nerve 6, inability to abduct, bottom of the base stem, think uncal herniation, increased intracranial pressure. When we deal with cranial nerve 4, that one gets a little weird because we start doing some things. So the affected eye might be slightly elevated, meaning slightly higher than the other one. And then the vertical diplopia is worse when looking down. So vertical diplopia, everyone understands. Let me see if I put a picture of it. Yes, I did. So there's different flavors of diplopia. Some things can be side to side. Some things can be stacked top and bottom. This one specifically causes things to be top and bottom. You can ask the patient and say, hey, I'm seeing double. Hey, does it look like it's directly above or to the side? Because that'll tell you which side the palsy is on. The other thing that we see with cranial nerve 4, the reason why it's weird is you kind of tilt your head one way, it gets worse. You tilt the head your other way, it gets better. So when we tilt it towards the affected side, that eye that's elevated ends up going up higher. The way I remember this, it's kind of like a German Shepherd where they give you the head tilt and they stack their eyes on top of each other, and then they flip it the other way, it gets worse. So this kid, you can see right here, this is the affected eye. When we tilt it toward that side, that eyeball is actually elevated compared to the other side. But when I tilt them away, the eyeballs start to look a little more normal. How will patients present then? They'll actually present with a mild head tilt. When I looked this up, there was a ton of pictures of little kids with kind of just like this little bit of a head tilt. And subconsciously they're doing it because it helps clear up their eyeballs. I don't know much about German Shepherds. I don't know if that's why they're doing it. I can only imagine what a veterinarian goes through every day when you don't know what you're going to see. All right, so cranial nerve 3, down and out. Cranial nerve 6, can't go abducens out. We think, hey, head bump, intracranial pressure. Cranial nerve 4, German Shepherd. Too easy, right? Sweet, love it. All right, cranial nerve 5. All right, everyone knows where V2 is, right? And then we have to guess if it's V1 or V3. Just remember, the heavier number is lower. You'll never get it wrong. Also known as the ophthalmic, the maxillary, the mandibular. I usually use 1, 2, and 3. You can expect that on tests. The big thing to remember with the trigeminal nerve is it can affect both sensory and motor. So making sure we're testing those masseter muscles. We're doing both the motor and the sensory. I think there was a question previously that said, which ones cover both? And I hated that question, but I would have. Don't memorize, hey, this one does this one. Just memorize, just pay attention to what cranial nerve you're testing. One of the abnormal findings that we're going to see affecting this cranial nerve is something called trigeminal neuralgia. That's actually a very painful stimulus to those spaces. We'll go over that a little bit in the future, just kind of keep that in there. All right, facial nerve. We see this a lot with stroke workup, and we see this a lot with Bell's palsy. So just get used to making the faces. Do it with the patient so they don't feel ridiculous doing it. But I say, hey, scrunch your face up like this. And then I open my eyes real quick so I can see them doing it. Make sure you involve the forehead. And if the forehead doesn't move, ask them if they have Botox. That's super common nowadays, and people's foreheads just don't move. Ask them. But I scrunch up the face real quick, and I tell them stop, and I say, hey, go like this then. And I keep watching them. But I make sure I grab all those muscles. As long as I do those two facial movements together, you don't have to break it down by individual. Very quickly and easily, you can see, hey, someone has a rock looking like eyebrow, or one's raised pretty significantly. So I saw this when I was working in the ER. It was a doc that had a guy that he was working for stroke on the main side. I was working the acute care side. And he runs into the room and says, hey, go like this. And the patient goes and kind of gives him the rock-looking eyebrow again. That's the slowest he moves. He gives him this face, and he says, all right, we can do this whenever he wants. Like, it's a facial droop. I think he's having a stroke. Why are we not paying attention to this? So we pay attention because different presentations will present differently. When we think a central lesion, they tend to be forehead sparing. because we're controlling it from a different portion of the brain. As the nerves travel out, they group together, and that'll cause the whole face to be affected. Bell's palsy, not as much of an emergency. We're still probably getting imaging kind of fast. But if we're putting our eyebrow up like this, we're looking like The Rock, we're thinking for the Bell as if we're in the wrestling ring, Bell's palsy. If we look surprised, we're probably going to neuroimaging faster. That's a quick, easy way to recognize this. This will save your butt in clinic a couple of times. All right, vestibulocochlear, I'm not going to spend too much time on air conduction versus bone conduction. We're not going to have crazy questions about which side does it lateralize to. Know how to lateralize and know the importance of that now. Because, hey, I have a hearing difference. Paying attention to which side of the brain is affected is important for ourselves. Does everyone feel good about air conduction, bone conduction still? Good. Which tuning fork do we use? This is a good question. You see them with the big one and you're like, I guess it works. I don't know. The smaller of the two. Is that correct? The bigger one we're looking for the
512.
vibrations in. Got it. Still got it. All right. Glossopharyngeal and the vagus nerve. These two can kind of be related to each other. We're looking at the uvula when we're saying, open your mouth, say, ah. Which way does the uvula point? Away or towards the lesion? It says away. Can someone explain why? So, your muscle on the affected side is having difficulty raising the uvula, so it causes it to point away from it. One side's going up, the other side's staying put, it's pointing away from the lesion. When we deal with the tongue and the SCM, we kind of shift sides, so just pay attention, like, hey, not everything points to the same side. When we're dealing with our tongue and hypoglossal with 12, does it point towards or away? Again, it's on the slide, I'm just trying to get people to repeat things. So the tongue points towards the lesion. The reason being, when I push my tongue out, I protrude, the good side is pushing the tongue, the bad side is not, so it's gonna point towards the side of the lesion. If you have difficulty and you're like towards, away, towards, just think about, hey, what's actually happening with the muscle? I can't push a rope. If I'm pushing on this side, great. If this side's not working, it's gonna point towards the bad side. Uvula, hey, one side's raising up, the other side's not moving. That's probably the side the lesion's on. One other weird one is the spinal accessory. We have them move their shoulders, we push against the hands. This is bizarre. This blew my mind when I actually read it. So when we push to the right-hand side, it's the right side of SCM that's affected, right? It's actually the left. So if you look, that sternocleidomastoid muscle, it's kind of attached right here on our clavicle. It actually attaches onto the back side of our head. So when we shorten up that muscle, that's actually causing your head to tilt to the right. Sorry if that got lost in the microphone. So when we think, hey, I have a lot of weakness going the opposite, it's kind of weird. You're like, no, there's no way. And you do it, and you're like, oh, that muscle is shortened. That's muscles contract. That's what they do. So when we say, hey, I have an SCM deficit on one side, I'm thinking cranial nerve 11. A lot of weakness going this way. Think the opposite muscle. Think of where it's attached. Yeah, that one blew my mind when I read it. Like, no, it was weakness on the same side. No, it's different. All right, hypoglossal, tongue points towards the side of the lesion. All right, motor exam, everyone's good about grading strengths. One of the things that I want to clue into onto this side is, do we spend a lot of time talking about upper motor and lower motor neuron signs? I'll kind of go over those because that's a reoccurring theme we'll spend a lot of time on in the future. So upper motor neuron, that starts in the cortex of the brain, that works its way all the way down the spine until it kind of hits that anterior nerve root. What we see with that, those are inhibitory. That causes the muscle to not happen as much. They control the movement a lot better. We see spasticity, that might be exciting movements. We see increased muscle tone because, hey, things are just kind of crimped up together. I think dinosaur arms, when someone gets hit on the head and everything kind of like moves up, we're very spastic right now. We might see hyperreflexia. That means when I do, the knee kicks out like crazy. I'm like, I hit his elbow, that's nuts. Clonus, we feel pretty good about that, where we do it and it kind of keeps repeating for a little bit. Positive Babinski's, is that toes up or toes down? Toes up? Positive? Cool. All right, and then we see muscle atrophy. That kind of develops later. And the reason being, when we have this kind of spastic paralysis, our muscles are increased tone, we have a lot of difficulty with movement a lot of times. It might not be complete. Because those muscles are flexed up more, it takes a longer time for atrophy to develop. And when we think lower motor neuron signs, I think floppy squid. It just doesn't move. Fasciculation's kind of weirded me out because that's always a common thing. That's just the muscle twitching but not having purposeful movement compared to dinosaur arms crimped up together. I have decreased muscle tone, and we're going to see that muscle atrophy sooner because the muscle just isn't getting that input anymore. It's just not moving at all. And then we may have hyporeflexia, meaning I test it and I keep it. Who has hyporeflexia here when we did like physical exam? Can't get it on anything. I'm bad for your partner, I'm sorry. Okay, and then strengths, we do pronator drift and 5-point scale. Everyone feel good about the difference between the different types of strengths? All right, pronator drifts. Everyone feel good about this one? Sometimes we do Romberg together with it. Close our eyes, see if we balance them. I'm okay with that for most cases. If we start having a lot of differences and we're like, hey, pronator was off and Romberg was off, do them separately and say, hey, this test was this test was that. For the stone cold normal people, I do pronator and Romberg every single time because it's very sensitive. Who knows what pronator drift actually looks like? So we're pronating and then we supinate. We pull up the ball of soup, or the bowl of soup, drop it over. Other things we can see is, I've seen it described several times where you kind of tap their hands and see if they can find that original position sense. One of the things that was, if we have that pronator strip, I'm thinking upper motor neuron. But if I see other movement or like their arms are kind of doing crazy things where I'll lose my position sense, think more position sensing things, think more cerebellar. All right, tendon reflexes, we're all good on scoring those out of a scale of 4. Cool, love it. 2's normal, 2 easy, never get it wrong. All right, I think I've shown this to half the class, but maybe not the other half. Who you guys have been exposed to this, the juniors maybe not. So, a lot of times I had difficulty with my dermatomes, and then when you bend over, it instantly makes a ton of sense. Think of it like we started off on all fours depending on the view of evolution. So with this, see 1, 2, 3, 4, and then L1, 2, 3, 4, S1, 2, 3, 4, 5. It all just kind of lines up naturally, as opposed to when you're standing up, it kind of like crosses the legs at like kind of awkward patterns. I just think of this anytime I get that weird dermatomal case. All right, do pay attention to these, especially for exam reasons, both for practice and for exam. As we're moving into what these different levels kind of innovate, these are very quick and easy to test. They've come up with pretty clean skills too. There may be some questions based upon this. So C5 likes to control the deltoid muscle for us. We're testing our biceps reflex. Sometimes you see 5, 6. I'm not going to split a question between the two like that. And then sensation, we're covering that upper portion of the arm. Does everyone know C6, 6 shooter, pew pew, finger goes like this, I'm sure if I'm on the video. There's a very quick, easy way to remember where that dermatome is for C6. And then honestly, when I localize these and I don't memorize them like several years later, I just remember C6, 6 shooter, and I go up or down to say, hey, here's C5, or C7 is my middle finger. All right, and we're thinking wrist extension with that one, and we're testing it with our brachioradialis. All right, C7, I'm thinking wrist flexion. I'm thinking I'm at the gym and I'm kind of doing the triceps extension because it also affects our triceps as well. Because we're testing it with our triceps reflex. And then dermatome-wise, C7 is just one down from C6. And then C8, I kind of think it's almost on that ulnar nerve distribution. It's the bottom 2 fingers. Who's ever bumped their elbow and gotten the funny bone? Did you feel it exactly? That's your ulnar nerve. This is a dermatome, not a distal nerve. I know sometimes we're like, hey, which one am I using? Is it a distal nerve or is it related to that? You have to look at the pattern and say, hey, I think we have neck pain and it's here. It's not the ulnar nerve that's affected, it's C8. You can switch between the two. You got a question? For C8, it kind of affects these 2 fingers, and it's very similar, like anterior, posterior, if that's what you're asking. Once you start dealing in the peripheral nerves, you'll start to kind of like, hey, the shape of the front palm or in the back. I'm not going to ask too many very specific questions on it. It's kind of hard to differentiate out, oh, this is an exact radial pattern versus a C8 pattern. That's very difficult to do unless you're sitting there pinprick and trying to map it out exactly. More commonly, I'm like, hey, do we have wrist pain or do I have neck pain? Because that's going to clue me into where the lesion is. That's a better way to localize it. Does that help you understand a little bit? All right, moving down, because we have our T, what's at our nipple level? T4 all day. It's that belly button. 10, never get it wrong. Okay. L4 for us, that's controlling foot inversion. That's controlling our patellar tendon. So I hit the knee, I think L4. And then S1, where's my S1 guy again? Sorry, I'm gonna make the joke again, but it sticks. My man, I'm so sorry. So if you're ever having difficulty remembering your S1 reflex, imagine your typical S1 clerk. It's a Thursday afternoon, and they got their feet, oh dang. They get their feet up on the desk, the heel, the Achilles tendons up on the desk, and they say, hey, we can't help you right now. Hips is down. That's S1. You'll never get it wrong. And then looking at the sensation, just think of the patient, bend it over yourself. Don't bend the patient over. Bend yourself over and just do it in the back room so no one sees you do it. Just say, oh, the dermatomes go back. So as I'm moving from the middle of the toe, it goes L4, L5, S1 towards the back, and then all the way back through. What's he doing in the break room? He's going over the dermatomes. Leave him alone. All right. Cutaneous reflexes, plantar reflex is another word for Babinski's. And we spend a little bit of time talking about the primitive reflexes. There's a ton of these. You might go over them a little bit in pediatrics. Don't memorize this chart. I'm going to show you for like, hey, there's a ton of them. So the reason why we have Babinski's as a kid, but then it goes away as an adult, upper motor neurons are actually suppressing that reflex that's still in your body. When the upper motor neurons don't work anymore and we have positive Babinski's, when those primitive reflexes are coming out again, that's a bad sign. That's why we do Babinski's as much as we do, because it's very easy to test. The reason why we have these reflexes as a kid is because they just help us survive. If you look, one of them is like a rooting reflex, a suck reflex. Those all help with breastfeeding. A kid that tends to breastfeed better is going to probably generationally do better from an evolutionary perspective. And there's a couple other ones. Again, there's not a question that's going to be based off of, oh, what are the primitive reflexes that we don't expect? Just know that the Babinski's fits within that. And then the fanning of the toes up, positive response, also known as plantar reflex. You'll see that in the literature a lot. I just want to make sure you guys know both of those names. Now, the superficial abdominal reflexes, don't pay too much close attention to that. I don't use those very often. And then cremasteric reflexes, we're stroking the thigh. We see an ipsilateral raise of the testicles. I don't do that very much. Last one is called the anal reflex. Does anyone know what that is or has witnessed that before? Also might be known as an ER handshake. This is a very common thing. Pick PRE, and then we're looking for anal tone, and if we kind of poke around the outside of it, you'll see a little bit of a wink, you'll see movement. Variation of this is called the vulvocavinal reflex. That's where you'll see images of it. You squeeze the tip of the penis, and you can expect to see the anal sphincter contract. If that's funny, it's okay, you can laugh. That's okay. It's a weird maneuver. Do we do this on every single outpatient? Who said yes? Y'all are unchained. Third one this morning.
Good morning, sir.
Why do you get the nurse to help you every time? It's wild.
Bro.
It is a two-person maneuver. This person is in the ER, they fell from height, they're unconscious, and we're looking to see at what level we can have reflexes. Babinski's, no, anal reflex is one of those quick, easy ones that tells you very quickly, hey, that's gone, this is bad, things aren't okay. ER handshake is a very common one. Just pay attention to the clues of like people in the ER of what they're doing. If they have you do it, just be very like, hey, I'm very professional, I know how to do this, and they'll use it as a means of like, hey, is this guy going to shy away from us? Like the very first ER patient, the main side I had, he handed me a chart and said, this guy needs a DRE, go. Okay, do I get history? No. He just expected me to do the ER handshake with this guy, and I did. I did it without flinching, and he went, all right, you're one of the good ones. That's a weird way to haze people. But pay attention to those reflexes there. He was old timey. We don't do that anymore. All right, sensory. You guys are very familiar with the kind of sharp bell, sharp bell, sharp bell, sharp bell. Do we do that with every single patient we do in the real world? Probably not. It's more focused for, hey, I think I have a radiculopathy, I have paresthesia going down this arm. I'm going to focus on this very specific region and try to tease those out. We have you do total body, if you kind of you're doing that on every single patient, you'll be there for hours. Do it while you're here. If you're doing a comprehensive neuro exam with a neurologist, break out the whole thing. If you're doing a very focused exam on a small part of the body, do sharp bill on just that portion of the body and light touch. All right, and I think to your question before about the peripheral nerves versus the radiculopathies, again, we kind of see a slightly different patterns. Don't drive yourself crazy trying to say, this one's this one's that. Localize it. Hey, I've got elbow pain. I'm thinking elbow pain. Hey, I got neck pain. I'm thinking more of a dermatome than I am a peripheral nerve. be comfortable switching between the two. All right, ignore the 5, that's not there. Shh. All right, landmarks, I think we got those ones down. All right, coordination exam, I think for the sophomores, we just went over this. The juniors, I do want to kind of revisit these real quick, because they'll be important for a lot of our movement disorders when we're teasing out the cerebellum, which is involved with movement coordination. We like to do rapidly alternating movements, tapping, having the patient do it on your hands. There's a ton of different variations, they're all cool. We're looking for something called dysdiadochokinesis. Ooh, that was a second good attempt. I always struggle with that word. What's dysdiadochokinesis? It's going to be a breakdown of that rhythmic movement that happens. And then that is more suggestive of the cellular dysfunction. Do I have patients come in complaining of dysdiadochokinesis? Oh, I did it really good. No, but if I do it on the phone with the neurologist and the patient's kind of doing one of these when he does it, and it's like, hey, I have a breakdown of rapidly alternating movements. I'm probably not dropping the dysdiadochokinesis word. I don't think you'll get that on the exam. It's important to know the doctor words as they exist, because you'll see it in literature. You're like, I don't know what that finding is. Go look it up. It's like, oh, it's a breakdown of rams. Got it. Cool. All right. Finger to nose. And again, we like to do the arm at full extension when we're doing the exam, because we're going to tease out some of those movements. I think some of the juniors, they might not have gotten that full exam, but making sure we're doing the full one, not just the back and forth, because you'll tease out that dysmetria. What's dysmetria? Metria, measurement. We're having difficulty measuring our movements as far as judging. All right, heel to shin. That one is very good for bedridden patients. It feels kind of weird doing it sitting. Again, we're testing that lower extremity. It's kind of like finger to nose, but for the lower half of the body. But again, very good for bedridden patients because they can move that around freely. And then walking, most important part of the neurologic exam. We'll go over some abnormal gaits. I think lesson number 3, it's a big boy, has a lot of videos in it because we show you pictures, like videos, like I clipped up a really good YouTube video of like the different types of gaits so you can just see one and be like, hey, I think that's a hemipyramid gait. I want you to guys see it, recognize it, there'll be some words with it, but we'll go over those at length together. And then cerebellar ataxia versus sensory ataxia. So we can have difficulty in the small part of our brain that coordinates movements, or we can have difficulty because our sensory system isn't working right. When we deal with sensory ataxia, it worsens when our eyes are closed, because then our position sense is thrown off. If it's the same between the both, think more so. I don't have an important test question on that. I think that was just kind of a wild G-Waze type thing, so don't stress that out too much. And then here's just a nice little organization. I had to look up what this double simultaneous stimuli was. It's not a test I think we've done. It's where you like poke the patient and blare an air horn if they don't feel you poking them. I thought that was strange. I've never seen that done in my life. Do we know what graphesthesia is? It's writing, you say, hey, here's number 1. All right, that's number 3. What's stereognosis? Is that the ability to have something in your hand, like, oh yes, pumpkin. You hand them a familiar object and a pen. You guys have done that on your physical exam. You say, hey, can you identify what this is? Correct? You haven't gone through the checklist yet with print skills too. I heard you tested on it. Last thing, that kind of covers the whole history of physical. We'll just go over some of the studies real quick. We're not going to spend a ton of time on them today, but what we do want to do is just kind of introduce them, because as we go through different disease states, we're like, oh, get a brain MRI with and without. We're like, cool. Why do I get contrast? Why don't I? We'll kind of cover some of the individual things so you understand the studies as a whole. And then when we go through the studies, like, oh, get an LP on that guy. It's like, oh, what are the actual contraindications? This is kind of the once over. Some of it kind of falls into radiology territory. So don't worry about that too much. All right, lumbar puncture. Who's ever had a lumbar puncture done? You, for real? Oh, we lad, you don't remember it too well? Oof. Lumbar puncture is you're awake and you're conscious. It can be a little bit more painful. You can do some lidocaine to help with it, but it's very important that we don't shy away from doing it. The reason being, the things that we're looking for with this are very serious, life-altering things. Meningitis, encephalitis, subarachnoid hemorrhage is another one. Patients with dementia that we're suspecting other causes. Again, you get some normal findings with that. Malignancy, multiple sclerosis, we see that happen a lot. And increased intracranial pressure, because we can measure what that looks like. Don't memorize this chart. I wanted you to just kind of get a generalized overview of what the findings of an LP actually look like. Oh, get an LP, and then you get numbers, and you're like, I don't know what the numbers mean. opening pressure. So we can get an LP and measure what that spinal cerebral fluid pressure is coming back as. The appearance will kind of give you a gross description. Most of the time it's clear. When we think turbid or bacterial, we start thinking meningitis. And then xanthillachromic, or does anyone know what that means? So that means there's blood inside the cerebrospinal fluid. So when they look at it, they see blood. That can be a traumatic tap, or that can be due to subarachnoid hemorrhage. So it's just a fancy word for bloody within the spinal tap. We check the protein and the glucose. Sometimes that can be increased, sometimes that can be decreased. If I see decreased glucose, that's almost always bacterial. The reason being that bacteria is eating the glucose that's naturally existing within there. Everything else doesn't really consume that. Protein can be increased or decreased depending upon what's going on. With bacterial, I got a ton of crap that the bacteria is letting off that can cause it to be increased. With subarachnoid hemorrhage, I have blood in there, so now that's causing an increased feeling of protein in there as well. And then lastly, I can get a white cell count. Neutrophils, what are those associated with? Bacterial infection. If I see lymphocytes, what's that associated with? Viral. You get it right every single time. It'll be okay. They'll give you those clues. Don't worry about interpreting LP findings. Just know that those are some of the findings and results we get, because we'll talk about hey, this condition has this. This is always positive. All right, this is important, both in testing, both in real life. All right, neuroimaging prior to an LP for CT without, if any of the following things are present. Because what we're looking for is making sure there's not increased pressure on the brain, because as soon as we poke into that spine, pressure starts to get relieved, the brain can start to herniate down and out because we've relieved that pressure. It's not like a squirt and everything shoots out. It's very small movement, it's very slight. But that pressure increased on the brain, what's the first thing that's going to go bad? That abducens nerve is going to start to disappear. We're going to start to see some double division, a lot of pain with that. All right. If any of these things are present, we need to go get a CT without a contrast first. It's going to be papilledema, which we know we feel very good about this one. See, that's actually a relationship. All right, seizures. If patients having seizures, we got to make sure we get that CT first. Altered mental status, and then new focal neural deficit. What's a focal neural deficit? Could be anything that is new, that is like, hey, this arm isn't quite working as right anymore, or hey, I have this new thing where my foot drop is developed. Anything that's like, hey, that's not this guy's baseline, I have something very specific, it's not generalized, pay attention to that. If we have infection at the site of where you're going to do the puncture is important too, and then coagulopathy, if someone has a low platelet count, why do we care about platelets when we're doing puncture? Clotting has to close back up. There's a couple of reasons why medications, warfarin, we don't like to be on warfarin because that's going to cause clotting issues. Make sure we stop it 4 to 5 days before. If urgent, you can reverse it with some fresh frozen plasma. Make sure their INR is back in. We're just basically putting more good more good platelets back into place and clotting factors so it works properly. Aspirin, NSAIDs, Tylenol, does that affect our clotting ability? Not enough to matter in this case, so we're not worried about this one. So if you see a patient on Tylenol and ibuprofen, you're like, oh, do I need to delay because of that? No. Clozapine, clopidogrel. Make sure we discontinue these 14 to 7 days before. We don't have a lot of reversal agents for those ones. All right. So the procedure itself, here you can see this is from I think this is from you and from a wee lab. We see the opening pressure being done here. They connect this little tube and it shows how high. It's not like a pressure gauge to hook up to your back, but depending upon how high it goes, that gives you a measurement for the pressures. And then when they actually collect it, they just kind of leave the needle in place right there and then swap the tubes out. They typically collect between 4 and 5 tubes. Sometimes that first tube might look a little bit bloody, and then the other ones kind of clear up. That's more indicative of a traumatic tap, meaning, hey, I poked some blood vessels on the way in, or I poked a couple of times, didn't quite get it. Where's the level that we actually like to do this? L3, L4. Why is that important? It's kind of that level with our hips, which is good physical exam sign for localizing that one. Where does our spinal cord stop and it just develops into nerves? Right at about L1. That's where that forces telcardia quantum into the hips. So we like to go below that, so we're not poking into the spine itself. We're kind of moving in between the nerves. And as you poke with the needle, the nerves will just kind of move out of the way naturally. They do. But if you're poking into the spine itself, go too high into L1, it's have a bad day. All right, post-procedure, this is important to pay attention to. A lot of people will have headaches after doing a lumbar puncture. Typically, it's positional, so it'll feel worse when they're upright, better when laying down. And that makes kind of sense. If I have decreased intracranial pressure that's causing me to have a headache, when I stand up, that pressure is going to be even lower and worse than my headaches. I'll lay down, feels better. Females younger in age typically are at higher risk for this. Post-procedure headache is caused by a drop in CSF pressure, got it. All right, the way we like to treat these ones, Tylenol, ibuprofen, very typical, very good. Caffeine is actually a really good one. If you want to hit them with the Excedrin right off the bat, no worries there. If we have refractory, like that headache won't go away, it's like 48 hours. I've tried Tylenol, it's not getting better. What you can do is actually called an epidural blood patch. So it's autologous, you draw off a little bit of their own blood, and you put it in the exact spot where that hole is. What that causes is the blood to clot up and create like a Band-Aid on the inside where that lesion is, where you're having a persistent CSF leak. But just know that the epidural blood patch is a good follow-up for people with persistent or severe symptoms. All right, EEG, the squiggles are extra mad today. All right, it's a non-invasive record of electrical brain activity, investigates seizure. Most commonly, I've seen this done by neurologists in seizure workups. They'll do one when they're awake, and then they'll do one as like a sleep-deprived one, so it's over like a longer period of time. You won't have to like interpret the findings of these, because I couldn't even tell you at the beginning what those abnormal findings will look like. Typically, you get a report with an interpretation back, and it might say something like, hey, no epileptic seizure, or no epileptic form seen, which, does that mean they have a seizure disorder or not? We don't know. That's why we're going to do the sleep-deprived one. If they still see a seizure activity, it doesn't really help us a lot. But if they see epileptic form, yeah, that's a little more concerning. Also used in brain death cases, where depending upon what state you're in, there's all types of different diagnostic criteria for brain death or not. This is sometimes used in it. You're not doing these personally, you're going to send off to neurology and say, hey, this guy needs an EEG that has seizure activity. It's the most common time we're going to do that. All right, EMG versus nerve conduction study. Who's ever had one of these ones done? Was it fun doing it? No? I agree with you. Did they zap you, or did they stick a needle? Or did they do both? Okay, so to differentiate that tissue, because I always just send people on like, oh, do an EMG on this guy. They do both. They're two different things. So what we're doing is we're measuring how well conduction is actually happening. An EMG records the intrinsic electrical activity within the muscle. That's that first one where you're poking with it. That's like your passive sonar. I think we got a bunch of Navy people in the other room. I think they make sense to them. What I'm doing is, the question I'm asking is, hey, does the muscle receiving responding to motor nerve inputs normally? I'm just kind of passively looking and seeing if the muscle's moving. Now, nerve conduction study, that's the one that is, they take a taser and they zap your arm. This is the little taser right here. And then they measure the movements down here. And that is asking, hey, can the peripheral nerve conduct, can the peripheral nerve conduct electrical signal normally? And that's like your active sonar, because now I'm zapping it with something to see what it actually does. So nerve conduction study, active study, seeing if things actually move. EMG, looking for passive, just sticking a needle. What was the worst between the two? When they tased you, the nerve conduction study itself. Don't worry about, I've been ordering it for years, not realizing they were two different things, because you'll get both results back. They just kind of block them together. They do one study, they do the other. If you send them off for EMG. Neurology can do it. More commonly, you'll see physical medicine rehab. A lot of times they'll have a physical therapist that can do it for you. What are some of the conditions where, do you mind asking why you got it done? What's that? Oh, dang. So they were testing to see if nerve jam, which was done. Cool. Well, another one, common one I see a lot more carpal tunnel syndrome. A lot of times they'll do that to determine, hey, do we actually have a conduction slowdown or not? Do we want to consider this guy for surgery even though it's been refractory? Some surgeons will ask for it. A lot of times they'll defer it and say, no, it's done clinically. Just see what the surgeon wants. If they want an EMG study done, they're looking to say, hey, is that nerve actually slowing down? We'll see this pop up during a couple of different disease states that involve slowing down of the nerves. Skull x-rays, do we like doing them? Me neither. I don't think I've ever ordered one. Medial port fracture, not a ton of use in it. Don't worry about it too much. We're probably doing a CT brain or MRI at that point. Takes the same amount of time to put it through. Does everyone know what the donative truth is? CT. It's way easier to do a CT. It's a 3D structure. It's very easy to miss fractures. Don't use it to make yourself feel better. Like, all I have was an X-ray. I showed a skull X-ray. You're not buying yourself any feeling better. You're just radiating people. All right. CT. done with and without contrast. Does anyone have a good feeling of when to order and when not to order contrast? It takes a little bit of time because you're in school and you're like, oh, always order with contrast because that's better. Honestly, 90% of the CTs I ordered were without contrast. The reason being, a lot of times I was looking for structure. The only time I order with contrast is I'm looking for vascular reasons. If you're really confused and you're like, I don't know which one to order, just talk to the radiology on call. They're actually super happening people and they'll tell you exactly what you need to order. Okay. Reasons why we like to do CTs: stroke, subarachnoid hemorrhage, gives us an answer very fast. Tumors, I'm looking for mass effect. Primary tumors and metastatic, secondary multiple lesions. If I have multiples, I'm probably thinking it's spread from somewhere else. Trauma, always a great one to do, and then dementia, because we're looking for anything that might be a mass effect. A lot of times in dementia patients, we might not see a lot of findings. Does anyone know what hydrocephalus is? Too much fluid in the brain. What would that look like on CT? You see those ventricles that might be enlarged. We'll go over that more in depth. I'm just curious what people really don't know. All right, here's a dumb question for you. How many chest X-rays equal chest CT? Like radiation dose wise? It's 160. Would you rather get 160 chest X-rays or I feel like the X-rays we feel is just for sitting there for 160 of them. Just know that, hey, before we punch the button on CT, there are cases where you need to do it, and there are times where you don't need to do it. If you don't need to radiate someone, just know it is a significantly higher radiation dose. Contrast nephropathy is something to pay very close attention to. Some people have allergic to contrast as well. They'll have that in the history. I think shellfish might be risk factors. A lot of times, there's no real contraindications to say, hey, this person has a contrast injury. All right, pay attention to that. But like, hey, this person might don't control the risk of doing that. The reasons why, don't memorize this one, just kind of keep it in the back of your head for when we want to order creatinine testing before we do CT. If they're over the age of 60, they have a history of kidney disease, family history of kidney disease, diabetes mellitus, hypertension. We have something that's causing us to have protein inside our blood that's abnormal, like in a multiple myeloma, collagen vascular disease, so some rheumatologic conditions, or solid organ transplant. What's the liquid organ transplant? Blood transfusion. Yeah. All right, that took me a while to figure out. I think older guys, problems with kidneys, something autoimmune-ish going on, I probably want to get a creatinine before. And that can be within the last 6 weeks, it's perfectly fine. We're just trying to establish a baseline, so if they do come back with nephropathy, we can say, hey, they were normal before, no, we caused this. Not everyone needs a CBCC before getting a CT scan. All right, MRI, non-radiation version of it. It gives us a lot better picture, especially soft tissue structures within the brain. But it takes a lot longer to do it. What we see with this, some of the complications, contraindications, it's a very loud machine. If we have an unstable patient, they're going to be there for 30 minutes. If we have a demented or ALS patient, we're not going to be able to get it, because even if we get them sedated, they're going to be moving around. It's going to create a ton of artifact in that. And then metal objects. Not everything goes out the way it went in. We have to be very careful about metal objects, implanted devices. If you can't get history out of a patient and say, hey, there's no metal in there, we have to be very careful about metal detection before they go in there. And then, what do we do for a patient that has claustrophobia? Give them a benzo. I do it. Originally, I was like, oh, you'll be fine. And then I realized how claustrophobic it actually is. Do them a favor, give them the benzo and involve their life. You can give them one outpatient, and that's like perfectly normal. People appreciate that. All right, contraindications. I think that's like a current. Pay attention to all things that could be in there. I think that cochlear, prosthesis, all those implantable things that could happen. A lot of things end up being non-ferrous. Things that are electrical though, those can malfunction. So pay very close attention to that. A lot of ortho things end up being fine. Some of the aneurysm clips, the surgical clips we can get within the brain, those are plus or minus. The biggest issue we see, has anyone seen an MRI artifact from metal? Looks like a bunch of rays of light shining off from it, like above and below the level on it. It'll end up hiding a lot of the detail you're looking for, even if it isn't non-ferrous. It's like when you look at teeth level, it just kind of like goes to crap, and you're like, well, that makes imaging the brain kind of difficult. You can go through these on your own. There's no test question based upon, hey, do they have this metal thing? Is it yay or nay? No, ask the question, do they have metal or not? All right, And then GFR, get a kidney measurement before they go out. Kidney disease, over 60, same things as with the CT scan. You can kind of block those together. History of hypertension, diabetes, or liver diseases. In addition to MRI is kind of distinct in that we're imaging the arteries to see exactly where they go. We can detect bleeds a lot more carefully. A lot of times if you order an MRI, they'll put it in as an MRA if you're looking, like, right in your description, hey, I'm looking for this. They'll change it to the appropriate order a lot of times for you. And then here's some various images of what it looks like. Last two studies to go over, I have something called a PET scan. What this is showing is the metabolic activity of the brain. Only about 5 to 10% of the brain that we're looking at any given time. It's a good functional imaging study in that it can show, hey, this person has dementia, unexplained. Do we have the same level of metabolic activity going on? It can be used for brain tumors because tumors use a lot more stuff compared to neurones. Difficult to diagnose movement disorders, neurogen disorders. This is kind of a follow-on study that the specialist is going to order for you. I've never ordered this for the primary care setting. And then myelography, don't pay too close attention to this one. I've never actually seen it done. Once MRI came out, we stopped using this. What we're doing is we're injecting contrast into the spine and shooting an X-ray to see where it's leaking from. Once MRI became a thing, it became way less common. This might be a good idea for someone that has something metal in their body that can't withstand an MRI. Then carotid artery ultrasound, very easy, non-invasive to do. If we're thinking about blood clots going up, we love doing this. And this can be either point of care ultrasound in the ER, or can be a formal diagnosis ultrasound done in radiology. And I'll hang out for any questions for about the next 7 minutes before you guys start class again. Sorry to go over by 3 minutes, but that's not too bad for the first one. Appreciate you guys.